So today we're going to talk about the Trauma Triad of Death, complications of mass hemorrhage and hemorrhagic shock. So despite little to no coverage by the media, trauma-related injuries are one of the leading causes of death in the United States and in the world at large, with hemorrhage itself being the leading preventable cause of death according to the Centers for Disease Control. Traumatic injury is actually the #1 leading cause of death in people aged 1 to 44 years, with unintentional injury being the third leading cause of death for all age groups. Hemorrhage and hemorrhagic shock actually account for 30 to 40% of all trauma deaths. So what does the normal clotting cascade entail? Well, when our blood vessels are designed to keep blood separated from collagen proteins and platelet activators that are in the subendothelial connective tissues, our endothelial cells normally secrete nitric oxide as well as prostacyclin, which work to keep platelets from sticking to each other as they move through our vessels. The plasma membrane of the endothelial cells also contains the CD39 enzyme, which is used to break down blood adenosine diphosphate into adenosine monophosphate and inorganic phosphate, which also keep platelets from sticking to each other. An injury to a blood vessel triggers vasoconstriction, the formation of a platelet plug, and the production of a fibrin web to return the body to hemostasis. As blood and collagen begin to mix, the platelets get triggered to activate, and they begin to converge toward the site of injury. The glycoproteins that are in the platelets bind to the collagen as well as to the protein called von Willebrand factor, which give the platelets the ability to anchor to the injury site, despite blood rushing past it with each pulse. When the platelets activate, granules that are on the platelets begin to secrete adenosine diphosphate, serotonin, and thromboxane A2, which activates other platelets and recruits them to make additional layers on the injury, resulting in the platelet plug. During this time, soluble plasma fibrogen is activated to change into insoluble fibrin, which is a fibrous protein that works to make a tight net or mesh that gets woven around and through the platelet plug, further securing it and turning it into what we know as a blood clot. On any given day, the average human has approximately 4.5 to 5.5 liters of blood volume. A healthy adult can lose between 10 and 15% of their blood volume and have no real noticeable effects. In fact, when you donate blood, you typically lose 10%, which may cause some slight dizziness, but a few minutes of rest and a glass of orange juice typically makes you feel better. Beyond that, though, your body starts to react to the loss of blood. Hemorrhagic shock is defined as severe blood loss, which leads to inadequate oxygen delivery at the cellular level, which then can start a cascade effect. Our body's natural reaction to hypovolemia from blood loss is to vasoconstrict and make our container smaller so that blood pressure is maintained. We also start our clotting process. Both of these processes use oxygen and ATP for energy. As we continue to lose blood, though, we have less red blood cells to transport oxygen throughout our system. Our oxygen debt increases, which causes cells to switch from their normal aerobic metabolism to anaerobic metabolism, the product of which is lactic acid. As lactic acid builds up, mitochondrial DNA triggers a systemic inflammatory response. Our ATP stores get used up, cellular homeostasis can't be maintained, and we begin to have cell death. As all of this is occurring, our body continues to vasoconstrict vessels due to decreased volume, shunting blood to vital organs. As arterial perfusion pressure continues to drop, blood will be shunted away from other organs and focused on our brain and heart, causing end organ damage or failure in the left behind organs. With extreme blood loss, perfusion pressure is not maintained, resulting in pulselessness and finally cardiac and brain death. The trauma triad of death, which is also called the bloody vicious cycle, consists of hypothermia, acidosis, and coagulopathy. Hypothermia and acidosis each can have horrible effects on a hemorrhagic patient, but when both factors are present in the face of hemorrhage and coagulopathy, results are almost always death. The entire system feeds on each other in a negative feedback loop. Hemorrhage equals hypothermia and hypoperfusion. Hypoperfusion equals hypoxic cells, which equals lactic acid production, which equals a drop in a pH causing your blood to be acidic. Acidosis plus hypothermia equals reduced clotting abilities called coagulopathy. and coagulopathy equals a loss of hemostasis, which equals cell death. On any given day, our core body temperature is between 35.6 and 37.8 degrees Celsius. Optimum temperature for most of our body systems to work is 37 degrees Celsius. Our temperature is regulated by the hypothalamus, which takes its cues from the negative feedback loop provided by the peripheral nervous system. When our temperature starts to fall, the hypothalamus sends direction to our skeletal muscles to start shivering to build up body heat. This process requires energy, which means it is causing an increased demand in oxygen consumption and ATP usage, all of which caused increased cellular respiration. Hypothermia is officially diagnosed at 35 degrees Celsius or less. In trauma, this can be caused by a variety of things, including some of the things that paramedics, nurses, and doctors need to do in order to treat the patient. One of the side effects of hypothermia is that it can cause our red blood cells to hold on to their oxygen molecules instead of releasing them where needed. This contributes to cellular hypoxia. Another side effect of hypothermia is that it impairs the normal coagulation process by slowing it down, as well as affecting how well platelets aggregate at injury sites and adhere to form clots. Our body likes to maintain an arterial blood acid-base balance in the range of 7.35 to 7.45, though some organs, like the stomach, prefer to be much more acidic. Absolutely nothing good occurs when blood pH drops below 7.35. Like a snake eating its tail, blood loss begets hypoxia, begets anaerobic metabolism, begets lactic acid, begets acidosis, and the circle continues the downward spiral if not corrected. With hemorrhage, acidosis plays a major part in affecting clotting factors, which are proenzymes. When the pH drops, clotting enzymes become denatured, inhibiting their functions. Acidosis also slows the effect on intrinsic and extrinsic pathways and can increase prothrombin times. The acidosis in trauma is usually as a result of bleeding, which causes low perfusion, which means there are less red blood cells for cellular oxygen delivery, making cells switch to anaerobic metabolism and lactic acid production. The lactic acid production will further decrease the blood pH, and when it drops to 7.2 or lower, we begin to see that the body has a decreased sensitivity to stress hormones and catecholamines, as well as decreased cardiac output and contractility. Due to not receiving the correct signals thanks to the adrenergic receptor impairment, our blood vessels begin to dilate, further worsening the hypovolemic problem, resulting in bradycardia, renal and hepatic dysfunction, ventricular arrhythmias, and eventually death. Coagulopathy occurs when the normal clotting system fails. This happens either due to having run out of factors secondary to hemorrhage, having used up all the available factors, or the factors have been disabled due to other issues like hypothermia and acidosis. This can also occur as a result of hemodilution from non-blood product fluid resuscitation. When tissues are injured, the endothelial cells recognize the injury and trigger the normal clotting cascade. In the presence of multiple injuries or mass hemorrhage, though, there is an increase in the amount of clotting factors released and activated. The body notices that there is way more fibrin and thrombin in the system than there ever should be, not understanding that this is because the body is bleeding out. To fix this, the endothelial cells begin to release tissue plasminogen activator, or TPA, which is also known as a clot buster. The TPA starts to break down the clots being formed and attacks the excess fibrin, resulting in hyperfibrinolysis. This dramatically lessens the body's ability to clot. Another complication of severe tissue damage is disseminated intravascular coagulation, or DIC, which occurs when the clotting factors are abnormally activated and begin to make small clots in the blood vessels where there are no injury. This causes vessel occlusion, which restricts blood flow to organs, resulting in organ damage and failure. It also uses up the valuable clotting factors so that they are not available to form clots at the sites of injury. Current science is showing that treatment of hemorrhagic shock, as well as treatment and prevention of the triad of death, is something that has been termed damage control resuscitation and damage control surgery. The term damage control itself is actually an old Navy term which refers to how much damage a ship could actually take before sinking and being lost. In the realm of healthcare, damage control is pretty much the same thing. how much a body can take before being lost. It is more of an approach to care than a specific treatment, with the end goals being early and aggressive correction of coagulopathy, increased oxygen delivery to the tissues, and preventing or treating acidosis. A return to homeostasis as rapidly as possible is the only thing that will save an exsanguinating patient's life. The main takeaway is to avoid or fix the pitfalls of the triad of death as quickly and as efficiently as possible. This starts in the field, with the ground and air paramedics focusing on stopping the bleeding with use of tourniquets and hemostatic dressings packed into the wounds to promote clotting. It also requires them to enact warming measures after cutting off the patient's clothes by using chemical heat packs, fluid warmers, blankets, and cabin heaters, no matter what the temperature is outside. Volume replacement is key in the face of hypovolemia, but most ground EMS agencies only carry 9% normal saline, which is usually cold and has a pH of 5.5, can disrupt clot formation, and doesn't carry oxygen. Many air medical EMS agencies, though, have started carrying blood products on board, so initiating blood volume replacement with whole blood or a combination of packed red blood cells and plasma is vital. Certain pharmaceutical drugs can also be used in the field, like tranexamic acid, TXA, which promotes clotting. Once in the hospital, continuing the measures that were begun in the field by keeping the patient warm, initiating mass transfusion protocols in a 1:1:1 ratio, performing rapid exams, looking for internal injury, and quickly getting the patient to the surgical suites, give the patient the best chance of surviving the trauma triad of death.